Good morning, afternoon and evening. The European School of Oncology welcomes you to their 336th e-session. Today's session is Highlights of ABC3, Advanced Breast Cancer 3rd International Consensus Conference. Questions will be received by Dr. Giuseppe Curigliano, of the European Institute of Oncology, Milan, Italy, who will discuss them with Dr. Fatima Cardoso, of the Champalimaude Cancer Center, Lisbon, Portugal. I will now hand over to Dr. Cardoso. Doctor, your line is now open.
Thank you very much, and thank you to all of you who are attending the session live and the ones who will be listening to it recorded. So today, my task is to present you the new recommendations for advanced breast cancer that were discussed in last November in Lisbon in the ABC3 conference. Before I start with the actual recommendations, I would like to tell you that also at ABC, we have presented a very important report about what happened to the field of metastatic breast cancer in the last decade. So you will see here that it's called the Global Status of Advanced or Metastatic Breast Cancer, a decade report. And you can also have the access to this report in full in these two websites, the ABC website and the specific website for the report. This report is a joint venture by the European School of Oncology and Pfizer Oncology. And it is a very important document because it helps us go through what happened in the last 10 years. I have, of course, no time to go through all of it. I will just point out some of the most important findings. So in the next slide, what you see is one of the findings, and that we already know from other studies also. So the survival rate for metastatic breast cancer is still very bad and slim. Only 1 out of 4 patients reach 5-year survival, so it's only about 25%. And what you can see here also is that in the last 10 years, we have not been able to advance this percentage a lot. It has gone through from 23 to 26 months, so not a huge advance to have in a 10-year time frame. So clearly what this means is that the absolute number of deaths by breast cancer is going to continue to rise. The incidence is rising, and therefore the absolute number of deaths will continue to increase. It is estimated that by 2030, we will have a 43% increase in the absolute number of deaths. So from 500,000 to 800,000 women in this case dying from the disease every single year. Now, also in the next slide, what we will be able to see is that it is slightly different for the cases that are diagnosed de novo. We know that de novo metastatic disease is not very common in, let's say, the developed countries, where it reaches about 10, 15, maximum 20%, but in the developed world, it can go up to 50 or even 60% in some countries. And this is not a result from the report, but this is data coming from the SEER database in the US, and shows that at 5 years, these patients have a 35% so 35% are alive at 5 years. So slightly better than the ones that relapse. So they are diagnosed as early and then relapse. Coming back to the report, another important finding is that, as we already know, for advanced breast cancer patients, communication with the healthcare professionals is extremely important. And they need this communication to be realistic, compassionate, and individualized. However, you will see that less than 50% of the healthcare professionals that responded to this survey said that they had training of specific communication skills. And we all know that in the vast majority of countries, this is not incorporated in the training of oncologists. Also, we recommend at ABC and also other guidelines that the discussions on end-of-life issues start as early as possible and be done in a smooth way as possible. Well, we have found that 65% of these discussions are held too late, in the very late stages of the disease, when it's far more complex to take decisions. We also continue to see that despite the advances that really happened in this last decade of speaking more about metastatic disease, of having advocacy groups dedicated to metastatic disease, there is clearly still a huge misunderstanding from the public regarding advanced disease, varying from 48 to 76% depending on the country. Most people do not understand that this is an incurable disease. And for me, one of the most disturbing findings of this part of the report is that about 1 in 4, and this goes from all the countries that we have researched upon, 1 in 4 from the general public believes that the patients with metastatic disease should not discuss it, should keep it a secret and discuss it exclusively with their physicians. So clearly this contributes to the stigma and isolation of these patients. But not everything were bad news from this last decade. So as some of you may know, the European Parliament has adopted a new declaration in the fight against breast cancer, and this was approved last year. And for the first time, it has a mention for metastatic patients, calling for their rights to be treated in a multidisciplinary specialized team. And this is extremely important because these patients also need a multidisciplinary team, also need access to psychosocial services, and need to be treated according to good quality guidelines. So now coming to the conference itself, as you know, this is the 3rd edition. This time we had 1,200 participants from 84 countries, and 66 patient advocates were directly involved in the program and discussion. Also importantly, these guidelines are the official ESMO guidelines for advanced breast cancer. They are also, of course, the ESO guidelines for advanced breast cancer. And for the first time, we had official representation in the panel from ASCO, and we have official endorsements and auspices from several other organizations that you see depicted in the slide. So clearly, overall, there has been quite a huge interest in the implementation of the ABC guidelines. So this slide is just to remind you that your views are very important, that you can take advantage of being online directly and send in your comments and questions, and we will address them at the end of the talk. So let's go to the statements. We will start with some general statements, as we usually do in ABC. This year we tackled 2 important issues. One of them is the issues of the type of clinical trials that are done. We believe that trials that try to answer important clinical questions are crucial trials, and these trials are usually not done. So trials are most of the trials are done for regulatory purposes, but we do need to answer important clinical questions, and we also need to have real-world data on the performance of new drugs, even after approval. So this is a plea for regulators and for companies and for cooperative groups to design and lead these trials. We have also tackled this issue that I believe it's very important, and we have heard a lot in these last maybe 2 years, both at ESMO, at ASCO and other conferences, discussions about affordability, cost, value of care, and how to tackle all these issues, both in the developed world and in the developing world. So what we did in ABC is strongly recommend the use of some objective scales. An example of that is the magnitude of clinical benefit scale from ESMO and also the ASCO value framework. So it is important to have an objective measure of what is really the benefit that the new treatment is bringing to the field. For lack of time, I will only very briefly explain to you what is the magnitude of clinical benefit scale from ESMO, focusing on advanced breast cancer, but I direct you to I direct you to the Annals of Oncology paper where it is published and quite well discussed. So in the non-curative setting, as we are in the advanced breast cancer setting, the value of, or the benefit of a drug is classified from 1 to 5, and only those who score 4 or 5 are really the ones who bring a substantial additional benefit to what already exists, and therefore we should try and lobby to have all patients accessing these drugs. This scale can be discussed in terms of methodology, but it only takes phase 3 trials, because those are the trials that gives us a most robust answer to a specific question, and also values survival much more than just progression-free survival. So if a trial has PFS as the only result, it cannot reach a score of 5. Then, and I will not explain in detail, but you can see in the paper, you can score the scientific results from 1 to 3. If it's only PFS, it's from 1 to 3. And then you also add in the scale toxicity and quality of life. And if the drug improves these two things, you add one value. If the drug leads to very high toxicity and therefore worse quality of life, you decrease one value, and therefore you obtain the definitive evaluation of the new treatment. So another issue that we discussed at ABC was, and we started already in ABC2, but we discussed quite a lot in ABC3, what we can call survivorship issues. And for me, this is one step further, because if we are discussing survivorship issues in metastatic disease, it's because we can already do it, meaning that some of our patients live long enough to have these issues of survivorship. So I see it as a very good sign. And what we plead for the physicians and other health professionals is to take these issues into account and be ready to change and adapt the decisions to the patient preferences, the patient's life plans, and also treatment specific adverse events. Let's give an example. Imagine that you have a patient who is a surgeon or a piano player, really needing the hands. You have to be willing to adapt and try to find a treatment that does not give or has a lower percentage of neurotoxicity. You don't want to ruin something that is very, very important for the patient. Also, we need to start looking into the chronic needs of this patient, both in terms of their home and family care, but also the job and social requirements. And particularly regarding the job, we have started to discuss that we need to lobby for some flexibility in working schedules so that these patients can go back to work or not, or if possible, avoid stopping to work. Not just because it is important psychologically, but for many patients, this is has an extreme impact in terms of finances. And some of the patients even go bankrupt, and the families, because of the lack of income and a lot of spending. Something else we have discussed is about the possibility of discussing with a patient that has a long-term stable disease to undergo breast reconstruction. So what we mean by here is, if it is clinically appropriate and the patient wants, it's not because she has metastatic disease that it should be totally out of the question to discuss breast reconstruction. And the same thing about following and looking into the breast, the operated breast and the other breast. This statement led to a lot of discussion, you can see in the percentage that there was no consensus. And my interpretation is that we are dealing with a situation that is very different from country to country. So we do have some, let's say, wealthy countries where too much imaging is performed, and we have in other countries situations where, because it's metastatic disease, then some other needs are totally forgotten. What we wanted to say with this statement is that if you have someone who has a stable for a long time, metastatic disease that is stable for a long time, you should not forget to examine and to perform some form of imaging of the breast, because it is also a site of either recurrence or a new tumor. And of course, if you have a suspicion of local regional progression, immediate breast imaging should be performed. Now, we have revised our recommendation regarding surgery of the primary because, as you may recall, two trials have been presented. So these are two small trials, have some difficulties, some pitfalls, but also have important results that we have to add to our knowledge. And in these two trials, we have not seen a prolongation of survival by operating the primary tumor, possibly with the exception of patients who have bone-only disease. Now, of course, this is a subset. The trials are already small and we cannot conclude totally. So what we can say now is that we have to consider the removal of the primary only in very selected patients. And of course, if we may need to do it for improvement of quality of life, we have to discuss it with the patient and tell her or him that we do not have a proof of improved survival when we perform the surgery. There are other trials ongoing, and some of these trials are bigger and have also important questions regarding what is the best timing, what are the best candidates. Only one last note is that if we decide to do surgery, then we have to perform it correctly. There is no such thing as a cleaning mastectomy or a toilet mastectomy. But if we perform surgery, then we do it with the same care as we do with early disease. Otherwise, you might as well not doing it. As we did in ABC2, we also tackle some important definitions. For ABC3, we have looked into the definition of oligometastatic disease. So this is let's say a very old definition, or let's say a very old term that was used or was defined to characterize those situations where you had only one metastatic lesion. However, we believe that with the advances of local regional techniques, we can now consider inside this terminology of oligometastatic also not just those who have one metastatic disease only, but every situation of low volume metastatic disease, for example, up to 5 metastatic lesions. So a limited number, also a limited size, but not necessarily in the same organ. Let's give an example. If you have 2 bone lesions and you have 1 liver lesion, both of them very highly responsive to systemic treatment, where you can consider local regional management of both the bone and the liver, we can consider that inside oligometastatic disease, since with local regional treatment we can aim for a complete remission. The other situation we defined was patients with multiple chronic conditions. The reason to define, it's not that it's a very difficult definition, but because these patients are extremely difficult to treat. Even the guidelines that we write are very difficult to implement in these patients because there are so many comorbidities that they have some severe contraindications for many of the treatments that we have. Also, it's to call the attention that very few clinical trials are done with these patients, and very few studies are done on how can we use certain drugs with liver impairment, how can we use certain drugs with renal impairment. And you know, we have these patients in our daily life, and we need to have more data on how can we treat them. So again, to remind you that your views are important and that we will address them at the end of the talk. So going now to the different subtypes. For the HER2 positive, I will not be able to go through all the recommendations, so the paper will come out in the next few months, so I will only give you the main messages. We have rediscussed this issue of what we can call the triple positive disease, so HER2 positive but also ER positive. And there is, what I can tell you is that there is among the experts less willingness to treat these patients with endocrine therapy and an anti-HER2 because of the lack of overall survival benefit in the data that we have. However, there are some highly selected patients for whom you believe that chemotherapy is not necessary and where you decide that endocrine therapy is a good option. In that case, what we recommend is that you do not give endocrine therapy alone, but you give it in combination with anti-HER2. And we will try to define these highly selected patients in the manuscript. On the other hand, the combination of endocrine therapy and anti-HER2 used as maintenance therapy is something that we use very often after stopping chemotherapy. It's, as you can see, majority of the panel recommends it, although we have not studied this strategy in randomized phase 3 trials. And probably, I might say that probably we will never do it. Now, the optimal duration of what we call maintenance HER2 therapy, particularly for patients who achieve a complete remission, is becoming an important problem. So, and this is also a good problem to have. So if we are able to induce a complete remission in a metastatic HER2 positive patient, and he or she is under trastuzumab, for example, for 3, 4, 5, 6, 7 years, when do you stop? We do not have any strong data to do it, and we have to balance the potential efficacy with the potential toxicity, logistic burden, and of course cost. So the majority of the panel believes that it can be considered, it is acceptable to stop the anti-HER2 therapy after several years of sustained complete remission. Maybe the patient is cured. Now, we were not able to define what is this several years. Is it 3 or 4 or 5? We have not defined it. And we also wanted to say that this can be done if you have the chance to re-challenge the patient in case there is a progression. In some countries, unfortunately, if you stop, you cannot reuse the anti-HER2 agent, usually trastuzumab, and in that case, we might as well not stop, or at least try to change the rules of the country. Now, specifically for first-line therapy, we have divided the patients in 2 main groups. So one is those who have not been previously exposed or treated with anti-HER2 therapy. So for example, those who are diagnosed de novo metastatic. For these patients, the combination of chemotherapy, trastuzumab, and pertuzumab is the standard of care because it has proven beneficial in terms of survival. However, and this comes in the next recommendation, for those who have already been treated in the either neoadjuvant or the adjuvant setting, which are indeed the vast majority of the patients in our clinical setting today, at least in the developed world, The combination of chemotherapy and dual blockade is an option, a very important option, but cannot be considered a standard of care. And this is because only 88 patients entered the Cleopatra trial that were previously treated with trastuzumab in adjuvant setting. And we also have the Marianne trial that did not show a benefit of a dual blockade in this trial, a dual blockade with T-DM1 and pertuzumab. So there are many open questions still about the ideal patients where the dual blockade should be used. These are some of the notes that we will discuss in the manuscript and that we can discuss at the end of the talk also. Now for the second line and beyond, we have not changed the recommendation, and here the data is very strong regarding the use of T-DM1, both as second line and also beyond second line, since it has indeed provided an overall survival benefit compared with either lapatinib capecitabine or with the physician's choice. However, we start having new questions to answer. For example, what is the efficacy of T-DM1 after a dual blockade with trastuzumab pertuzumab? Now, for the first time, we also try to discuss and give some recommendations regarding the chemotherapy component of the treatment of these patients. So what we decided to do is, if you are not giving pertuzumab, okay, let's imagine that you decide that the patient does not need pertuzumab, or that you are practicing in a country where you do not have access to pertuzumab. So your first line treatment would be trastuzumab with a chemotherapy agent. So the preferred agents are vinorelbine and taxane. There are differences in toxicity, and it is important to consider and discuss this with the patient. Particularly, we have two randomized trials, small trials is true, but we have two trials that compare vinorelbine trastuzumab with either paclitaxel or docetaxel and trastuzumab, and in those trials vinorelbine was superior. So something to take into consideration, and as I usually say, a taxane that it doesn't always have to be given as first-line chemotherapy agent. For later lines of chemotherapy agents to be combined with trastuzumab, as you know, we can combine almost everything. So we have done this list of the most frequently used, but it's not exclusive. There may be some other agents. We must discuss the toxicity profile with the patient. We also have to take into account what the patient received previously in our decisions. Now, if we can and we decided to use pertuzumab, then the chemotherapy agents for which we have data so far are docetaxel and paclitaxel. We have stronger data. We have a study called Velvet with vinorelbine, but so far Velvet has only reported toxicity. So we are waiting, and probably this year it will report efficacy. And also with a lower level of evidence, we have now paclitaxel. I believe that in the next few years we will see more and more agents being used with this dual combination, but for the moment these are the data that are available. Now, two specific points regarding brain metastases in HER2-positive patients. So if a patient develops brain metastases, but the extracranial disease is stable, the recommendation is not to change the systemic therapy, but of course to treat with local regional techniques that we have already discussed in ABC2. The other situation is when brain metastasis is the only site of recurrence. Now, we do not know that the addition of chemotherapy adds anything in terms of the course of the disease. But we do have some data, retrospective, but although retrospective, all in the same sense, that you should restart then T-HER2. The stronger data is with trastuzumab. So if trastuzumab was stopped, you should start again. because the overall survival is better if it's under trastuzumab than if it's under nothing. And of course, never to forget that this is in addition to the appropriate local therapy. Now going to the luminal cancers, again, I will only give you the main messages. And I know that these messages, this particular message was already there in ABC1 and ABC2. But because I consider that this is the message and the recommendation that it's present in every single guideline and it's not followed in the majority of clinical practice, I'm always putting it up there. So unfortunately, recent research regarding what physicians actually prescribe show that the first option for first-line treatment for luminal cancers, advanced cancers, physicians still choose chemotherapy, varying from 40 to 80% of cases. And this is very unfortunate because for these patients, even in the presence of visceral disease, the most appropriate treatment is endocrine therapy. Now, for postmenopausal patients, and we now have, and we have put it 3 options with the same level of evidence, and it actually depends on what the patient received in the adjuvant setting and what was the time that elapsed since the end of adjuvant endocrine therapy. And then you can choose between AI, tamoxifen, or fulvestrant. We still do not have either a biomarker or very strong data to choose among these agents, depending on what was received in adjuvant. By the way, this year we probably will have the presentation of the Falcon study that is a head-to-head comparison of aromatase inhibitor and fulvestrant in this era where most patients have received aromatase inhibitor in the adjuvant setting. So a very interesting trial. Now, we have also tackled the question of adding or combining 2 endocrine agents. This was the first time we made a recommendation about this. And what you can see from the percentage of voting is that there's not really a consensus, but most of the panel members will not use this combination. But it's a possibility, it exists. You have two trials, one showing a benefit when combining non-steroidal AI and fulvestrant, and another trial, also well-designed, also phase 3 and large, not showing any benefit. Now, there are some subset analyses, but you already know that subset analysis must be taken very carefully. But it seems that it is only the patients who have not been exposed to previous endocrine therapy that benefit from this combination. A little bit like we have seen with pertuzumab, trastuzumab. Those who had not been previously exposed to treatment respond better. But for the vast majority of our patients who receive some form of adjuvant endocrine therapy, there is controversial data on the beneficial of adding 2 endocrine agents. Regarding the use of everolimus in combination with the aromatase inhibitor, we have not changed the recommendation. It is an option. It is not a standard of care. It is an option. It has to be balanced with the toxicity and the fact that it provides progression-free survival benefit, a substantial, but no overall survival benefit. However, we will discuss in the manuscript, there are some studies, more recent studies, showing that this combination has an excess of mortality in elderly patients. And this is something we need to either prove or disprove, but we need to pay attention when using this combination in elderly patients. Now, we have also started to tackle the use of palbociclib, acknowledging, of course, that this is not available outside the US, but probably with the presentation of the results of the Paloma 3 trial, we will have some discussion around this in Europe also later this year. So what have we done here? We have discussed as first line, and as first line, what we have is the results of a phase 2 trial. impressive results, is true, but it's only a phase 2. And we have seen quite often in our lives of researchers that results of phase 2 don't hold up in a phase 3. So until we have the phase 3 results, we do not consider that this can be recommended. We know that it's available in the US and used. However, we do not think that it is a good option without the phase 3 data. As you can see, there was a lot of discussion in the panel and not really a consensus about this. Now, for the use of the palbociclib combined with fulvestrant beyond first line, and this is for pre, peri, and postmenopausal, we do have the results of a phase 3 trial that shows a substantial PFS benefit, actually very similar to what everolimus provides as a PFS benefit. We still do not have overall survival. It was still very early. We need longer follow-up. But we have something different from everolimus, and this is the improvement of quality of life, something that we do not see with the everolimus. So we do consider that this makes palbociclib a very good treatment option for this setting beyond first line in combination with fulvestrant. As it happens with everolimus, we do not have a good biomarker to help us identify who are the patients who benefit most, and we need to continue to look for these. We have to admit that many efforts have been made regarding biomarkers for everolimus, but we have not been able to find one that is good. We hope that we can do better with CDK inhibitors, and the research must continue. Now, something that we really do not know, and we cannot recommend or help you, only with our personal view, is what is the optimal sequence of all these endocrine agents. So you do have a list there of available options, including the use of estradiol. But to tell you what is the correct sequencing of all of these, particularly when the combination with palbociclib comes into place, we actually do not know, and a lot of research has to be done regarding sequencing. This is why we made the first recommendation, clinical trials addressing important clinical questions, like what is the best sequence for the individual patient. Now, regarding premenopausal women, we went through available data regarding the use of ovarian suppression and ablation. And despite the fact that we have mostly old data, we kept the recommendation because all the data we have point for the importance of using ovarian suppression or ablation as the standard for premenopausal women with advanced breast cancer. Now, not alone, but in combination with an endocrine agent. And this endocrine agent can be an AI or tamoxifen. Also here, you will have to look into what the patient received in the adjuvant setting. And for example, if a patient relapses while on tamoxifen, personally, I would be more willing to put her on an AI plus ovarian suppression ablation. If she relapses on an AI with an ovarian suppression ablation, probably change to tamoxifen. Fulvestrant is becoming also a very good, valuable option for premenopausal women, but we do not have enough data to use it without ovarian suppression ablation. So we need to pay attention to that and also perform more studies on the use of this drug in premenopausal patients. So again, to remind you that we would like to receive questions and opinions, and we'll discuss it in the end. So already almost finishing, what can we recommend to triple negative? Basically, to tell you that for those who are not associated with BRCA mutations, there are no data to tell you to do differently. So all the recommendations that we give for the treatment of HER2 negative disease also apply for the triple negatives that are not linked to BRCA mutations. However, we did make one recommendation because of the TNT trial, the trial that compared docetaxel and carboplatin. And what we say here is that we can add this agent as a very good treatment option for triple negative advanced breast cancer patients because it had comparable efficacy and a more favorable toxicity profile than docetaxel in that trial. Now for BRCA-related cancers, and these can be triple negative or endocrine resistant metastatic disease, and you have received anthracyclines and or with or without taxane in the adjuvant setting or in first line, then we have a preference for a platinum, because also in the TNT trial and other trials we see a substantial difference in the efficacy of platinum in this particular situation, so BRCA-associated cancers. For everything else, the recommendations are similar to sporadic metastatic breast cancer. We call the attention to the importance of discussing with the patient the possibility to have genetic counseling and eventually genetic testing, particularly if you have a clinical trial where the patient can enter, for example, a PARP inhibitor trial or any other trial that needs the BRCA testing. For the first time, we have also mentioned the very good option that is metronomic chemotherapy, and I personally use it a lot in my clinical practice. It's very well tolerated, it's done orally, and it can control the disease for a long period of time with very low toxicity. What we know better is the regimen cyclophosphamide methotrexate, but there are other regimens being studied of metronomic chemotherapy. We call the attention that because our patients are receiving less anthracyclines in the adjuvant setting, don't forget that these are very good agents with a very high efficacy in breast cancer and can be used in the metastatic setting. Because of lack of time, I will skip the bone metastasis and just tell you something that I think we are facing more and more in our clinical practice. So patients can have the sequencing of their tumors they can ask for it through the internet even. And they come to us with the results, and we actually do not know what to do. And for the clinical trials that have looked into the use of this technology, we have not yet been able to prove that we can do better using the results of the sequencing. So for the time being, this is a research priority, but it's not ready for clinical practice. We have also issued important recommendations on how to manage some symptoms and also some important toxicities from these new agents. And I will direct you to the manuscript where you can see how to treat cancer-related fatigue, neutropenia, pneumonitis, endocrine toxicities, and other symptoms. So also don't forget that what is not revoted is not because it is forgotten, it's still there, and many of the recommendations of ABC 1 and 2 still hold and will be published in the manuscript. And the manuscript will be published simultaneously in the Breast and Annals of Oncology as it was previously. And very rapidly, I just want to thank all the patient advocacy committee who have done an extremely important job. Also, all the panel members, including your discussant today, for all the work they have done, and all the co-chairs of the meeting and all the ESO staff. So finally, to tell you the dates of the ABC4 that were changed regarding what we announced in ABC3. So this will be 2 and 4 November 2017, and I hope to see you all there. Thank you very much for your attention.
So thank you very much, Fatima. You did a great job, I believe. I would like to thank you for doing this, for all the people with metastatic breast cancer, and for creating a space for advanced breast cancer. I remember the first time I met you a lot of years ago, you told me we need to think about advanced breast cancer. And this achievement is a global achievement, and you did this. This is very important. We have a lot of questions for you. So I will try to go through any one of these single questions. They are very interesting. So the first question is related to surgery in the metastatic setting. Is there any certain situation, biologically or clinical, that you recommend mastectomy for a de novo metastatic breast cancer?
So let me tackle this in two ways. First of all, I do not think it has to be mastectomy all the time. So I would prefer the question to be, do I recommend surgery of the primary for a de novo metastatic patient? Because you can have metastatic disease and a small tumor that can be treated with breast conserving surgery. And there's no need to go for mastectomy. And yes, I do use it sometimes in selected patients in my clinic, particularly those where a very good response is obtained, or those who have limited metastatic disease, where I can also try to tackle the metastatic site and then achieve a status of complete remission. So in selected patients, I do suggest or discuss in the MDT the possibility of having surgery, but not always at all mastectomy, very often even breast conserving surgery and the treatment of the axilla.
So we have a second question. This is very interesting, I believe. So if you have a patient progressing after adjuvant treatment on trastuzumab with a disease-free interval very short, would you consider also in this case a dual blockade, or would you consider to change the type of entire to treatment?
Well, this is, I skipped this issue because I couldn't discuss everything, but this is one of the things we will discuss in the manuscript. We have no data for these patients, unfortunately, because you will see that both in Cleopatra and in Marianne, patients who entered the trial had a 12-month disease-free survival at least. So for those who relapse in the first year, we actually do not know what is the best treatment to give. Maybe it's to change completely and to go straight to TDM1. We do not know. If you ask me empirically, without data, I would say that maybe we should try a dual blockade, because, you know, these patients do very, very badly. We all know that usually they do not respond neither to the dual blockade nor to TDM1. So if they do not respond at all to trastuzumab, usually prognosis is very bad. But it's something to decide, but purely without data to support it.
Very good. Another question. This is about tumor dormancy. Are there any data regarding first-line endocrine therapy in patients that relapse after 10 years of adjuvant treatment? For example, TAM for 5 years and AI for 5 years.
And then relapse and what to do?
Yes, yes.
So, I don't think we have enough follow-up to say that, but if we know very well that those patients who used to take just 5 years of endocrine therapy, the vast majority of relapses occur in the year 6, 7, and 8. So 1 or 2 years after stopping endocrine therapy. That's why we started the trials of 10 years. I think now we need to have more follow-up and practice of those who receive 10 years and see if they start relapsing at 11, 12, or 13. Again, without data, my personal feeling is that it will happen. And then maybe we will need to do 15 years and 20 years of endocrine therapy. It may be that we don't actually cure a lot of breast cancer and we need to give some continuous treatment. But, you know, this is my personal feeling and I don't have data to support it.
And again, in elderly women, would you prefer a second-line fulvestrant or everolimus exemestane?
So, you know, I do use everolimus in the clinical practice, but I do select also the patients to whom I propose. And particularly, for example, if you have someone, it's not because of age. I will not say that I don't prescribe everolimus to everyone above 70. That's not true. If you have a very good fit patient, even if it's above 70, with no comorbidities, who lives nearby and can come to the hospital because of side effects, I don't see that this is a problem. But you need to think of the biological age of the patient. If it's fragile, then I am not sure that everolimus is less difficult than a chemotherapy agent.
We have a lot of questions. They are arriving. So now we move to triple-negative breast cancer. If patients have not been treated with taxanes and anthracycline, would you also consider carboplatin as first line? It's not specified if BRCA mutated or not, but this is the question.
Okay, so we have no data for that, right? Because the data we have from the use of platin are for the patients who have received at least anthracyclines. They did not all receive anthracyclines and taxanes, but they had received at least anthracyclines. I don't know. The fair answer is I don't know. I think in a BRCA mutated, I would probably go for cisplatin-based treatment. In a non-BRCA mutated, probably not.
Another question, again on metastatic setting and chemotherapy. Could you please provide some details on treatment regimens for metronomic chemotherapy?
So at the present time, where we have a lot of publications is with the use of CM, so cyclophosphamide and methotrexate. There are trials ongoing with either vinorelbine or vinorelbine plus capecitabine, or with different regimens of capecitabine given it in a lower dose, in a more continuous way, so without the interval. So, but these are regimens that are currently being studied, not yet published, not yet strong data. So for the moment, if you would like to use metronomic, and as I said, I do use it quite often, I use CM or in some situation, you can also use cyclophosphamide alone as metronomic chemotherapy.
Another question on triple negative. Would you treat a triple negative patient with capecitabine monotherapy?
Yes, in a very selected type of patients. So triple negative, we all know that triple negative is like a black box where you put everything, right? And there are very different types of triple negatives, and there are some situations where you have minimal disease. There is relapse, yes, but there is not a huge relapse. There is not a lot of visceral disease, and the patient is totally asymptomatic. So why not? The discussion about the response rates of capecitabine in triple negative is quite controversial. In some studies it was very low, in other studies it was quite okay, but these studies did not select the patients, so they put all triple negatives together, and it's complicated. I hope that we will be able to dissect the triple negative and find out what is best for the different subtypes inside the triple negative. But to be fair, it's something I consider in some situations of triple negative.
Then we have a lot of thanks for the presentation. I should mention this. And then, should patients treated with breast conservative surgery in the setting of advanced breast cancer, should they receive conventional radiotherapy as well?
So we have few data regarding surgery, but we're starting to have more trials. But regarding radiation, we really have not a lot of data. We have some retrospective series, and we are not able to dissect if there is really an advantage to give radiation. Now, what I think is that if we have, and this we have data, that if we perform surgery, we should perform correct surgery and address the breast and the axilla. It seems a bit odd that we do that and then we don't give radiation. So if you do the surgery just because improvement of quality of life, I don't think we need to do radiation. But if you have done the surgery aiming at achieving a complete remission, in that situation, I think we need to discuss radiation also.
Another question on triple negative. If you have a triple negative breast cancer, de novo metastatic, BRCA mutation detection and treatment to target BRCA gene is recommended or not?
So what we try to address with that recommendation that we issued is that if you are going to change your management based on the BRCA results, then you should counsel the patient to consider the testing. If you have no clinical trial, and if in any case you have already decided what type of chemotherapy you're going to give, and the only difference is are you going to give platinum immediately or not, then you need to think what benefit can that provide to the patient. And again, the issue of testing is very personal because it affects not just the patient, it affects the family. And you have to tell the patient, look, there is this possibility, either in a trial or outside a trial, or I will treat you the same way, it's just to have additional information. So it's something to consider, but not blindly to everyone.
And now you will like this question, I believe. So sometimes you have a very, very well designed phase 2 randomized in which you will obtain outstanding preliminary results of progression-free survival. So do you agree in recommending the use of this specific drug before overall survival results are released?
Well, without making my life more difficult with the FDA, I do not agree with approval of drugs based on phase 2 trials.
Phase 2 randomized, phase 2 randomized.
Yeah, even phase 2 randomized. I do not agree with that. I think we need the phase 3. We have several examples of extraordinary results in phase 2, and then they did not hold up in a phase 3. Regarding the issue of overall survival, everyone knows that I'm a firm defender of overall survival, but I think a drug can be approved based on PFS results, if it provides good PFS results. Where I see it differently is that it doesn't necessarily mean that it becomes the new standard of care. If it only provides progression-free survival, then you have to balance your decision with the toxicity, with the cost, and with the other available options. So if you have no survival, you have to take all these into account. But I agree that with PFS, you can have an approved drug. With only phase 2, I disagree. So personally, I would not have approved palbociclib based on just a phase 2. I sincerely hope for the good of our patients that the phase 3 shows as good results as the phase 2 and that it's published very quickly so that we can also have access in Europe.
Now we have a question from India. It's a very provocative question. Many patients in India are very poor and they cannot support the cost for treatment. And the question is related to Herceptin specifically, because many patients have no access to trastuzumab in the adjuvant and in the metastatic setting. What do you recommend for HER2 positive breast cancer patients that in India have no access to trastuzumab in the metastatic setting?
So I've had this discussion several times with my colleagues from India. It's a huge problem because even if they have been able to decrease the cost of trastuzumab, they can barely prescribe it to the early breast cancer patients. And clearly, when you have limited resources, obviously you need to focus on giving trastuzumab in the early setting, aiming for curing those patients. Even trastuzumab is only palliative in the metastatic setting. So I agree with that decision of focusing on early breast cancer. And even there, the vast majority of patients in India do not have access even in the early setting. So what we used to do several decades ago when we did not have trastuzumab, was to treat these patients with chemotherapy. And the chemotherapy agent that works better, at least in preclinical and some clinical data, is anthracyclines. Also the taxanes, but anthracyclines are quite good for the HER2 positive disease. So if they have not received that in the adjuvant setting, that's what I would recommend for the metastatic. Knowing that without anti-HER2, the HER2 subtype has a bad prognosis.
And now, for patients with triple negative breast cancer, which chemotherapy regimen would you recommend if they received the neoadjuvant anthracycline and taxanes and they relapse with metastatic disease after 1 year of hormonal treatment? So ER positive, neoadjuvant chemotherapy, 1 year of hormonal treatment, and they relapse. Which is your recommendation?
So you will have to take a lot of things into account. First of all, the age of the patient, if it's pre or post-menopausal.
Correct.
Not the age itself, but if it's pre or post-menopausal. Also, the volume of the metastatic disease. Is it a very important metastatic disease, very symptomatic, or is it mild and not symptomatic with not a lot of burden of disease? And then I would consider always as my first choice a possibility of giving again endocrine therapy alone or in combination with a biological agent.
Yes. Another question for triple negative disease. So the question is, would you recommend BRCA mutation detection in all patients or in selected patients in case of metastatic disease?
I think this is quite similar to the other one that you asked me. It's personally in our current clinical practice, we have a trial that we can offer the patient. So we tend to recommend more, at least to discuss and to have the counseling and eventually the testing. If I didn't have a clinical trial, I don't think I would suggest so often the testing.
Okay, now we have many thanks for the discussion, great discussion. And another question. In case of BRCA mutated patient and metastatic disease, do you believe it's recommended oophorectomy?
Well, in the metastatic setting.
Yes, of course.
So I skipped one of the recommendations that we discussed, and we went on discussing what is the best way to perform ovarian suppression in the metastatic setting. And some of the panel members, quite a lot of them, believe that surgical ablation is more efficacious than a medical suppression. Not everyone was in agreement with this, but there is some data, not strong, but some data showing that you can perform a more profound suppression of the function of the ovaries if you perform an ovariectomy, and that is particularly important if you want to use an aromatase inhibitor. Yes. So taking all that into account, if you have a luminal cancer, independently if it's BRCA or not, you may suggest more frequently to have ovarian ovariectomy. Now, if the question was if I do that because of the risk of ovarian cancer, I would tend to say no, because in principle the probability of dying of the metastatic breast cancer is much higher than to develop an ovarian cancer. So I would consider ovariectomy if it's a luminal cancer and I want to suppress the function of the ovaries. It's also more convenient than to have the injection of an LHRH every month.
So we have now 15 minutes of discussion, so I have to take just the final question. So just the final. It's very interesting, this question. So which is for you the recommended time interval for the evaluation of treatment response in metastatic breast cancer?
That's a good question. And
yes.
And if you go to the ABC1 recommendation, we have a statement regarding that. And it was also an interesting statement because we couldn't reach a consensus. And we discussed, and then finally we understood that the American colleagues were fighting to do less imaging because in their country they have the problem that many patients have imaging done every single cycle. While in some other countries we were fighting to have more imaging done because in some countries patients go through 6 cycles without any imaging evaluation. So what we come up with a consensus was that usually you should evaluate by imaging every 2 to 3 cycles or every 2 to 3 months of endocrine therapy, probably more often in the beginning until you are sure that the treatment is working, and then you can, if the patient is stable, increase the interval. But this also depends on the type of the disease that you are dealing with. If it's a slow-growing disease, it's useless to do very often imaging. But if it's a rapidly growing, then probably you need to do more often. So adapt to that and follow the patient in the rest of the time by physical examination, by eventually a blood test, and you can use, this is the situation where we can use tumor markers. If they were high in the beginning, they can help us by showing the effect of the treatment.
Thank you very much, Fatima. A lot of questions are still coming, but I would like to conclude with 2 comments. Thank you very much for this very educative session. Thank you very much, Dr. Santos from Mexico. A lot of thanks. So thank you very much, Fatima, for your time for this very, very exciting seminar.
Thank you, Giuseppe, and thank you to all. Bye.
Bye.
Thank you, Dr. Cardoso, and thank you, Dr. Curigliano. Ladies and gentlemen, the session has now concluded. Thank you for participating, and have a pleasant evening, day, or night. Goodbye.